Good morning, everybody. Hope you've all been able to log on and welcome to this webinar this morning, where we're going to be looking at outcome measures in early intervention and psychosis and strategies for how we can kind of utilize these outcome measures and see if we can kind of improve the number of measures that we're collecting. The webinars are being recorded and they are going to be uploaded to the NCAP website, so please be mindful. There is an interactive section, so any of that interactive bit can well be kind of recorded. But please don't let that stop you from engaging and kind of joining in and being part of it. We do want it to be as collaborative and kind of engaging as possible. So please do, when it comes to that interactive session, kind of join in with us. So in terms of the clinical audit, it's a really great team that we get to work with. Mike's our medical director. Joe and myself were appointed as clinical advisors, and it's a role that I've thoroughly enjoyed working in. It's great to connect with colleagues right across the country, and I know that Joe, who's on the webinar, will echo that. We have an incredibly active service user advisor and service user advisor group, and that's coordinated by Vinu, and Vinu is central to the team and kind of collaborates with us on all aspects of the audit, and it's something that we kind of try to ensure that is built into every single thing that we do. And I think Vinu absolutely keeps us on track and is a great colleague to work with. CCQI staff, there's a number of people who kind of sit behind the scenes, who do all of the hard work. Ella, Zoe, Bethany, Samira, Beatrice, Alan, Claire, Emily, Brigitte and Stephanie. They're all incredibly hardworking, and as you'll see in relation to the data, there's an inordinate amount of data that's collected and has to be gone through, and the number of teams that we work with. So huge thanks to all of those guys. So in terms of today, who's involved? Well, I have got the very enviable. I'm very, very pleased and proud to be kind of setting us off on the webinar, and I'll be talking about some of the data. There's not a huge amount of data to go through, but I'll kind of introduce that. And then Joe's on the line too, so you'll be able to put questions or comments, and Joe will be able to kind of add to the rich discussion, which is great. And then leading the webinar and the technical side of things, we've got Jessica, Emily, Naomi, Stephanie and Natasha. So hopefully if anything's not working quite right, one of those guys will be able to help or might be able to advise. We obviously have to acknowledge, in relation to thinking about audit and audit data, COVID has absolutely overtaken all of our lives and has impacted on us in a huge number of ways, not least of which the thought about how we kind of think about what we're doing and auditing what we're doing. We've seen that EI community has been so impressive throughout all of this. We've absolutely looked to innovate, we've looked to ensure that we continue to deliver the interventions and services for people who are just so vulnerable. And a huge thanks from myself and the rest of the team for all the incredible work that's gone on and that we've been able to witness over the last few months in order to overcome some of the real kind of challenges. There are a number of support systems. I'm sure that you may well have looked at some of these, but if you haven't, the IRIS website, RC Site website, CQC and gov.wales all have some really excellent resources, and we continue to evolve some of the resources. NHS England, NHS Improvement continue to have additional webinars too. So please make sure that you utilise all of those, and I hope that you're starting to come through some of the difficulties that we were experiencing over this past few months. And so I'm going to get on and share some of the findings from the report. Usual caveats apply. So let's crack on. So for the Welsh Case Note Audit, we had a total sample across all of the health boards contributed, and we had a total sample of 205. And that number of 205 is going to be really important to bear in mind in relation to all of the data that you see in the final report that comes through. Because what we've seen is it's been a real joy to be involved with our Welsh colleagues. There's been a real enthusiasm from all of the clinicians that Joe and myself have been able to kind of connect with over the last kind of 18 months to 2 years. We've been working with you over a period of time to kind of, initially start to generate interest in the audit, start to kind of work with you to kind of, get in a place where you might be able to align to collect some of the data. And this is the first time that you've been able to put forward the results that we've been able to actually, put into a report format. So this is incredible, and we're really, really pleased and proud of all the work that you've done to get this point where you're now starting to collect data, and we're starting to see some of those results. You've done incredibly well to get to this point, but I think what we also can see is that there's large variation and the fairly small numbers. So any real kind of thoughts on what this means for people with emerging psychosis and first episode of psychosis is hard to generalize out, but it's an incredibly powerful start. So just to give a sense of comparison, in England, and for our English colleagues who have joined the webinar, the English case note audit had 10,500 people in the sample, and that was across every single trust, and every single team in England contributed to that audit. The standards that we actually audit against, you're all, I would imagine, acutely aware of these. We look at the kind of time it takes for people to get into treatment. We know that we have that 2-week kind of wait aspect. Then we look at the intervention strategies, the psychological interventions of CBT and FI. We look at whether or not people get access to clozapine, which is very important for those people who've had 2 or more treatments that haven't been effective. We have an interest to understand the take-up of supported employment and education programs, because they are so important for people. And we're even more tricky, I think, following some of the economic decline that we're likely to see in relation to the current kind of COVID issue. But we know that getting access to supported employment and education is so important for people with emerging psychosis. For a long time, it was kind of ignored, but it's such an important thing. Joe has done an inordinate amount around that kind of work. The other aspect which we know was ignored for a long time, and that wonderful kind of mantra of colleagues like David Shires about don't just screen, intervene, the Leicester tool that David worked on for many years, is now absolutely ingrained in all of our thinking. So we absolutely look at physical health, not only reviews across all of the smoking, alcohol, substance misuse, BMI, blood pressure, glucose and cholesterol, but what are people doing once they've done those measures? For a long time, we used to hear that people had said, oh yeah, well, we've measured that. But the intervention part, and we're really, really keen through the audit to look at what people have done. If you find that people are smoking, if you find that people's kind of, glucose levels are abnormal, what are you doing in order to kind of change that? We also look at carer take-up for the education and support programs, and the focus of today is very much on outcome measures. That's the prime reason that we're here today. We're not going to be looking at all the other data. We have all of that. That's going to be in the reports, but we're here today to talk about outcomes, and that's HONOS, dialogue, and QPR, and whether we're keen to understand whether or not they've been assessed on 2 or more occasions, so that we can see a trajectory of change, a trajectory of recovery. So, availability of clinical outcome measures for people who use our services. So, this is the Welsh case notes audit data. 2 or more outcome measures for dialogue or other. As I mentioned before, we've got 205. What you see here is, so you've got all the bars of the different health boards, and you've got an additional one which shows what's called the TNS. So that's the that's the average from all of the different health boards. And what you can see is you kind of got one that's starting to do really pretty well. You know, it's approaching 30%. But we've got some massive variation then. You know, we got another kind of health board which is below 10, another which is kind of, you know, close to about 3%. And then we've got 3 that are not doing any. So we've got lots of variation. So how can we learn from the organisations that are doing well on this and share that across the others? Because that's the key point. It's about really generating some change. What we know is that when we kind of engaged with you last time, we saw that there was kind of no outcome data being collected. This time, that average, that national average across Wales is that we got 5% of people who've got 2 or more outcome measures at the different time points. Now, whilst that may look quite disheartening, what I'm going to show you is the English data to demonstrate actually we were in a very, very similar position to Wales not that long ago. So you can see there is an ability to ramp things up. And I think that's incredibly important. So going from 0, you're now at 5%, which can look, you know, oh, we've got somewhere to go. You have, but it's a great, great start. So huge well done to any colleagues who've been involved in that. So for England, this is where we're at this year. So out of 10,560, we're now over 40%. But as I mentioned, if we go back only a couple of years, we were at 9%. That doubled up to 22 and doubled again to 41. So I guess our challenge to colleagues in Wales is, can we see that exponential rise in outcome data collection over the next coming years, and to learn from some of our colleagues who've done some really fascinating work. What's really vital and what will come through from all of the talks is that this isn't just, it's not for Joe, it's not me, it's not for NCAP. The reason that we're collecting this data and we're trying to encourage people to collect this data on outcomes is because that's what we always predicated EI upon, that we were recovery orientated. The measures that we have here are recovery orientated. We're looking to see whether or not we're doing what we set out to do. People who use our services are keen to know whether or not the interventions that we're delivering are having an impact on their recovery. So this is very much about clinical teams and people who use our services. This is what it's all about, not about us being able to say, oh, look how fantastic it is. We're delighted that we're seeing the numbers increase, but we're delighted because it has a real kind of ability for clinical services and people who use our services to understand what's actually kind of, you know, driving recovery or not, as the case may be. So we wonder now if anyone has any questions that they want to ask of, we've got Maureen, Joe and myself available to kind of answer any questions that you may have regarding the questions. They were going to go to a more of a discussion section after that, but any questions that people have regarding the presentations that we've had to date, that'd be helpful.
So Paul, we have one from Peter, which Joe has already answered in the Q&A, but just for the benefit of those who are joining by phone, Joe, would you like to answer it again? So it is, with the outcomes received, has there been any regional areas that show more positive results?
Yeah, and I thought it was a really interesting question, because certainly in previous years we have seen regional variations, for example, in family intervention, and that has actually led to regions investing in family intervention training and trying to support regions which were behind. I don't have that data here because on the regional differences in this, but I just wanted really to highlight from the graph that Paul showed, which covers the 57 trusts. So within that, most trusts, we're talking about maybe 2 EIP teams contributing to that bar graph. And what is interesting is that 26 trusts were performing at level 3 or higher. That's 46%, just under half of teams who are level 3 performing well or exceptionally well in relation to this. And I think that's reflected in what we've seen over the last 2 years, because we've seen a doubling year on year from 9% to 22% to 41%, where there's been collection of outcome measures at baseline on 2 or more of those measures and a repeat. So we've seen tremendous progress in implementing measurement in practice. What did happen last year in 2019 was NHS England ran a webinar, which I think was very well received, on improving outcome measurement. And if you hadn't had a chance to look at that, that's also worth looking at. It goes through some of the things we've covered today about scoring and also about use, but clearly what we've seen is huge improvements, huge. And what I would encourage regions to think about is about the opportunity to build on this webinar, to sit down with teams, to share on strategies, to share on how people have successfully managed to do that, what they are doing at both either an individual level or at a service level to improve that collection.
Okay, thank you. And another question here from Pam. So some of our staff struggled to complete the blood glucose and lipid questions, as the questions on the audit tool use different unit measures than PathLab, where they get the data from. Can the audit tool be made to reflect the way that PathLab record results?
That's a tricky one. I know from personal experience, when I was in working in early intervention, we had 2 teams, and in fact we had to review the collection of glucose because the 2 teams were using different measures. What it's based on are international measures recommended by either IDF, the International Diabetes Federation, or World Health Organization. We're following their guidance. So I'm not quite sure quite what this is referring to. There are different ways that you can measure blood glucose and lipid, but we're actually following international guidance for comparability. I don't know, Pam, in response to that. I don't think that we can list different things, because then that opens up. We are following guidance from international experts and in terms of international classifications. I don't know, that's maybe something we can pick up and have a look at, but maybe that's something that would be worth actually, if you can provide an email address, that maybe we can follow up afterwards in relation to understanding that in a little bit more detail. But as I say, that what we're using is based on what are agreed international standards.
For Maureen, what would you say was kind of your key point from your presentation today?
Gosh, that's an interesting question. I think the mistake that people can make when they start doing improvement work is to not do so within context. If we're being asked to change something that we're doing, the implication is that somehow or other we've been doing something wrong. So I think that when you're embarking on improvement work, it's really important to make sure that people realise that it's generally the systems that have caused things to be the way that they are, rather than the individuals that are involved, so that you're working together to try and find solutions that can address the systemic issues. And if it's actual behaviour that's driving a failure in practice, then that's generally for good reasons, not bad reasons, and people will be open to changing their practice if they're involved in helping decide what those tests of change are going to look like. And that's one of the great things about working with the model for improvement, is it encourages you to be testing things out in a very small scale, safe way. And I think that's the bit that's kind of so hard to impress upon people, that it's so different from previous ways of working, because it's very much about getting the team engaged, then coming up with their own solutions, and then being surprised by how much you learn from things not working as much as you learn from things when they do go, before they do make improvement. But sometimes we have ideas about what's going to make things better. When we try them out, it's not actually the correct answer, but we've learned something along the way. So yeah, taking people with you, not blaming people, and just getting everybody engaged and working together.
Are there any more comments from our leads? Or
I was going to make a comment, so it's Jo here again, which is one thing when I was working in early intervention was we did collect data, and people sort of felt it went into a black hole and wasn't really looked at as a thing. And one of the things that we did at our away days was actually doing what Kathy did, which was to take some existing data that we had on anonymized on individuals, showing how the data could demonstrate progress, but also pulling that together based on the data we actually had, to look at how we were doing in terms of the experience of our service and in terms of outcomes. So we didn't change anything initially. We just used the data that we had to look at what we had. And that, for the first time, I think for some people, the penny dropped, that it wasn't about the process of collecting data, it was the value of what lay in that collection, both for an individual and service. And I think Kathy's presentation showed that. And so one thing might be to take some of the data you've got, either for an individual where you've got a baseline and a follow-up measure, and take a series of those to look at what it's showing, or to take a combined set to actually look at what it's saying about the experience of service. And I think, just going back to Paul's presentation, where we saw that in the case note or audit, up till now, we've just looked at the collection of measures, and we can see that now at the minute, we have 4,646 people where we have a baseline and a follow-up score on two or more of those measures. And you can begin to see now that with data collection getting close to 50% having that with 4,500, we can begin to use the data, which was always the plan, to actually look at real outcomes on a national scale in terms of what early intervention services are achieving. So I think at this time of COVID, at this time when resources may be challenged because they've been diverted into COVID, that actually it's really important that we do collect the data, because we can use it to actually now look at outcomes of EI and demonstrate what I think we all know, which is that we are improving outcomes for young people and we are delivering a good service. But this is an opportunity to show it and defend EI. So I think in the time of COVID, when we might feel challenged by collecting data, it's actually probably very important that you can see now with 4,500 cases that actually we will be able to start saying quite a lot about the outcomes achieved by EI.
Thank you, Jo, and thanks, Paul and Maureen.
Just one more point, if it's okay, Emily, just to finish off as well. I guess just to let people know that we had planned with our regional kind of meetings that we were going to invite teams who'd done, really innovative things with data. And unfortunately, due to the fact that we ended up having to do webinars, it made that a bit trickier to do. But certainly we've seen teams across the country who've started to make real use of this data, not just to say, look how well we're doing in terms of the audit, but to look at what they're doing with their clients and to look at the impact of their service on their clients and start to use the scores in terms of all of those measures to really start to drive their practice and care. And I guess that, we were hoping that we were going to be able to make that very much part and parcel of the workshops. It's proved a bit tricky, and that's why we went for the kind of the video from Kathy, who gave a really nice overview of that. But we have teams right across the country who are starting to do really innovative things to drive patient care with this data, not just at a national level, not just at a regional level, but an individual level for people who are getting care through EI. So this is a really, really important thing that we want to try and keep going, because it would be easy to drop off during this year, and it would be a crying shame if it did.
We've got one question in the Q&A box here from Beth. How useful do service users find the QPR and dialogue score conversion, or do you tend to focus more on individual domains?
I'm not quite sure what is meant by the conversion bit. I guess what we do know is that clients absolutely value the opportunity to look at any data on, kind of improvement. And I guess it depends on where things are at for that individual. So if you're concerned about one specific aspect of your life, then being able to track that over time, whether that's as a single item, whether that's as a domain, whether that's a total score, I think it's about making it, kind of important for the individual. We know that for a long time we've not really been collecting that data at a national level and probably at a team level. So all we've been collecting to date is, are you completing those outcome measures on a regular basis? We haven't had the scores. So any ability to transfer that information in relation to scores, whether that's an item level, domain level, or a total score level, I think it's going to be a real bonus. So I'm not quite sure what the question was aiming at, but anything that we can do that improves our ability to collect outcome data is going to be really important. And certainly our client feedback regularly is that they find it incredibly helpful.
So we've got a couple more comments coming in, which I think maybe the top two we could leave for the discussion. But there's one from Dave here. Are there any longer term plans to use the data from the dialogue and QPR for research, e.g. looking at relationship with clinical outcomes rather than for NCAP alone?
That's a great question, Dave. And so we have an inordinate amount of data. Certainly the data that flows in, we have to make sure that we utilise it. The team that we have at NCAP is actually quite a small team with, although you see a number of names, not everybody contributes full time. Not everybody contributes to the NCAP audit on a regular basis. We have some people who kind of, work on other audits and support us at other times. So there isn't a great deal of resource to do all of the interesting questions that we want to ask of this data. We absolutely need to be at a place where we see, well, actually, if you're an EI team, that's a standalone EI team that's delivering all of these interventions and you're getting great outcomes, and we look at another team and we look at their data on outcomes and they're not getting some of them, then actually that gives us even more credibility about saying, well, why aren't you delivering all of these kind of interventions? Is it because you don't have the skill set? Is it because you don't have the funding? Have you been commissioned sufficiently in order to deliver these interventions? So I think we're going to be able to ask some really rich, important questions of this data set. And whether that means that we kind of engage more with the research community. I know that if we've had other people from the research community say, can we get access to some of the data? Obviously that would have to be anonymized. It has to go through certain processes. A request has to go into the NCAP team and that will go elsewhere. But I think that that's likely to be something that we have to do. We have to make use of this great data to drive forward change and understand whether or not the kind of service structures and models that we implement actually deliver the outcomes that we wanted to. So it's a great question.
Thank you, Paul. We have another question here from Lynn. Will the results from last year's audit, which are due out soon, show levels achieved for teams, as this will help our current QI projects and reflect on successes implemented last year?
I could answer that quickly, which will be yes. So I presume that the question relates to the level 1, 2, 3 and 4. Yeah, we will be showing the levels. Now, I don't think that will be the same for our Welsh report. I don't think that will be the same because those levels are not the same for Wales. But for those people who are our English colleagues, yes, the report will have that level 1, 2, 3 and 4. And absolutely, this is about, you know, QI strategy, enables you to see where you're at, enables you to set goals for where you want to be and check whether or not that's actually happened. So yes, that will happen.
I think we've got a comment in the chat here from Julie saying, I wondered if you have plans to continue this format as the accessibility using Zoom, I believe, will widen access, and as an audit lead at Norfolk and Suffolk NHS Foundation Trust, I am encouraging staff to view this recording.
Yeah, I mean, I think we all have learned from perhaps the positive side of COVID, as it's forced us to move into a much more technological age and use medium like this.
Is a repository of change ideas that have been demonstrated to work for others that is held by NCAP? This might support providers to learn from others.
Not as far as I'm aware, but one of the outcomes of the webinar is to try and, in the discussion, get that kind of feedback from the field in terms of examples about how people have used the data for individuals or as a service to demonstrate improvement, because there's two different things there. I mean, one thing that we are aware of when you look at the data Paul presented is just the tremendous progress that's been made. You know, 2 years ago, 9% of individuals had 2 or more outcome measures. And now it's up to 44%. So each year it's doubled. Now, early intervention services are doing something to achieve that. And when you think about that number of cases, 10,500 cases, that means in over 5,000 of those case records, there were 2 or more measures. Just think about that data set, and just think about within teams, typically where there's 100 service users, that you've got data both for individuals to look at change, like Kathy showed, but also as a service to begin to put your money where your mouth is. And I'm really confident, having worked in EI and worked with EI, that it will demonstrate changes, positive changes in terms of recovery and satisfaction and quality of life, because I know it from working with service users that those measures will show the changes that early intervention is achieving. So any examples people have got in the discussion section now, please feel free to speak up, raise your hand and say, and we'll be happy to record that, because this is all being recorded.
I think we've actually got some comments here in the Q&A section that would be quite good for the discussion that's coming up. So from D. Kenny here, I lead on FI, and when I do family measures, I offer CCs the opportunity to also send out outcomes or do in session along with family measures. CCs seem to appreciate this reminder and or help quick wins.
Great.
And then from Lynn, we've got the future collaboration platform as a good resource and platform for sharing good practice.
So I think that takes us on now to the next part, which is a discussion. And this offers people the opportunity to raise your hand via the magic of Zoom. And if you do that, one of the great, I think Steph probably will do some tech stuff, be able to unmute you so that you can actually contribute verbally. Clearly, we've seen year on year an incredible improvement in outcome measure data collection. How on earth have you achieved it? And how can we share that with colleagues that are really struggling? And the other question that we're really fascinated by is, are you actually using that outcome data? And if so, how? So it'd be really great to hear from people on any of those points and sharing what you've done with regards to those things.
I've got someone who's raised their hand here. I'm not sure of your name, but I'm going to unmute you.
Hello, I'm Sue Dugan. I'm from Northamptonshire NCAP Early Intervention Services, the operational manager there. in your response to how we're using some outcome data, I suppose one of the things that I've been doing in Northamptonshire is using HONOS and those that around the organisation have been scored as first episode psychosis, HONOS 10, and I get a report on a monthly basis, so I can identify around the organisation where people have come into the organisation and not been referred. So I can track them and have a look at those cases to try and get them into the service.
Have you shared that elsewhere, or is this, you know, and is that practice across your kind of trust, or is that just at a team level?
Well, it's any HONOS 10 that comes into the trust. Get a report from our performance team, and then I can actually go through the cases with my team, and we can identify whether we've missed or those referrals haven't been sent to us for whatever reason, if they are appropriate, and we can then work with those services to sort of educate and try and get earlier referrals into our NCAP team. So it's a local thing, but for the whole organisation.
Right. I mean, that's a fantastic strategy for ensuring that you're seeing the right people right at the beginning. Have you done anything in addition with HONOS data, you know, for people who then get into EI and then to track HONOS data in terms of their improvements?
Not particularly the HONOS, but we are using QPR and dialogue to do that through our care planning and team discussions.
And how you find
tricky, really, because I think it goes back to the presentation about teams sort of understanding what the purpose of the data is for, and perhaps the fearfulness that it is about performance rather than clinical practice. So I don't think we use it as well as we could, and it's a huge piece of work that we need to do, I think, not only in Northamptonshire, but I'm sure everywhere. I'd be interested to hear others' experiences on how they're using it to inform practice, really, and improvement.
Well, it sounds like a great opportunity for anybody else to contribute.
So we've got a couple of other people who've raised their hands.
Hi, I'm Peter Carter. I'm a consultant in North East London. One thing we did was to try and collate all our audit data onto an enormous Excel sheet. But then in January, we started to look at that data for ourselves, which was really useful in highlighting differences between the 4 teams in the trust and producing our own local and trust action plans. I think you're absolutely right in what you say in looking at the dialogue in more detail and seeing what it really says and comparing scores over time. And I think that's where we need to make progress over the next year, certainly in the trust. But it fills me with no enthusiasm to have to enter those scores into the NCAP submissions. And I think that's where it becomes very time and labour intensive.
It's such an important thing, Peter, and it's great to hear that you're using the data in a good way locally. Clearly, this is your data. All we're doing is helping the process of bring it all together and enable NHS England to have an overview. So using your data is absolutely vital to these improvements. Now, we've been desperate, certainly Joe and myself as kind of clinical leads have been desperate to kind of ensure that the actual scores are collected. When we went for our interview, we said that this is one of the things that we really want to move towards. But the concern was when we had such low levels of numbers of people actually collecting that data, that it may be seen as, just not being reasonable, and we needed to move the system on. I think now that we have, we've reached this incredible figure of doubling over the last 2 years. We've got 40% of people. I think we're now really, really keen that we have some way of collecting those scores, and that's absolutely on our to-do list. And then hopefully, again, local teams will start using those actual scores within their own systems of care to see whether or not the interventions they're offering are making a difference to their client. And going back to the point that was made before, this can't be seen as being about performance management. This has to be seen as being driven by our clients and our clinicians as valuing it. And then if you try it and you use it and it's not that, we need to do something else. But I'm sure, going back to the conversation from Kathy, lots of our service users really value the opportunity to see whether or not the treatment plans that we put in place have an impact on you know, their outcomes, their recovery rates, etc. So I think people will. Great point.
Can I make a comment really in relation to that, which is, I can understand that feeling of we're feeding a beast, like the NCAP beast. But actually what we've seen is that this beast has led to investment locally, regionally, nationally. Actually, the collection of this data has a purpose, and it's actually not about necessarily performance, although obviously we are looking at trying to improve that. But we've seen national investment this year, which came about through NHS England wanting to invest in EIP. And I think in these times of COVID, where we're all going to be paying back huge amounts of money and resources are going to be very tight, I think this may be a protection for EIP. And certainly the reason why I say that is because obviously this year we did the service user survey, and when you see the data from that, I think you will all sit back with pride. I certainly was proud of EIP services in England, because those service users unanimously talk about the value of EIP, the receipt of services, the experience of care coordinators, psychiatrists, involvement, collaboration, all the things that when I was involved right from the beginning, right from 1993 onwards, what we wanted to achieve. It was just such a pleasure to see that data. And I am confident that we'll also see that mirrored in improvements. I can't see how it couldn't be in terms of the service users already reporting, and you'll see that in the service user summary, which will be coming out with the national, both in the national report and also as an appendix at the end. Huge improvements. And I think what you need to try and get around is this is a chance to showcase both your service locally within your trust and also nationally to actually put money where our mouth has been about the value of EI. And so rather than see it as feeding the beast, this may be a protection. It may protect resource. It may also, and we certainly have seen that, lead to investment of resource and keep a focus on EIP. So I think this year is particularly important to try and get stuck in with the audit, because I think this is one way, and I know NHS England and HQIP share that view, that there's a risk if we took our eye off the ball that it could lead to disinvestment just because of the lack of resource that will be around. So I really encourage you to rather say it feeding the beast. This is an opportunity to showcase, but also protect, and also maybe lead to investment, which it has done over the last 3 years that it's been running.
What do you think some of the barriers are to getting the outcome data collected routinely?
Well, I think that really nice presentation from Kathy kind of highlighted some of the key aspects. I think one is that people have really felt that they've not had the time. I think time has been a real issue for people. We know full well people in EI services are inordinately busy. They really have. They've delivered 100% and more over the last few years. And we've seen that we've impacted not just on the 2-week wait, but all of the items in right throughout the audit have increased year on year, and people have really delivered. So huge thanks to that. But I think there's also that sense that again, Kathy alluded to, which is, oh, well, why are we doing this? It just seems to go into this black hole and it's just data collection for data collection sake. And hopefully what we can move towards now is, now we've got that process of people starting to collect data and moving beyond a sense of just doing it in a frustratingly way or not engaging because they don't know what the value is. I think we're going to be in a place where we're going to be able to demonstrate the real impact on patient care that we have. And all those points that Joe really nicely made, which is, you know, once you start to have those items of data, you can really utilize that at an individual and a service level. So getting our clinicians to have this data and getting our clients to have this data is so, so important. But I think time and uncertainty about what happens, that black holeness, a couple of the big ticket items for me, Steph.
And also, Maureen, do you have any kind of solutions to getting outcome data collected?
I think it very much depends upon having a clear understanding of why it's not happening. It could be that the data is not being collected, and therefore you have to then understand why people are resistant to collecting it. Is it because they haven't got enough time, because they don't think it's going to get used, because they don't think it's their job, because they don't think it's of any value, because they think it potentially challenges the therapeutic relationship they might have. So if they're not collecting, obviously you can't then use it. But I would imagine that there's instances as well where data is being collected, but as was said by Kathy and Joe, it's not being used in the correct way. I can't imagine having been a residentialist myself in my early career. I'd have loved outcome data to be around then, so actually able to see the fruits of your labours. I think as individuals, we don't stop often enough to reflect on our own progress. We're down on ourselves. So I think, as was beautifully illustrated by the quotes from Kathy, people do when they're encouraged to reflect, then I think it can be hugely uplifting for individuals to see their own progress. We tend to be very present now, don't we? We don't reflect on, well, last week this felt bad, but now it feels a lot better, and I know why that is. So now I actually have a bit of a solution here should this problem arise again. So yeah, it's going to be horses for courses, isn't it? But I think when I spoke earlier on about the importance of diagnosis, it's so important. Don't second guess the reasons why the data isn't being collected or isn't being used. Really try and work with people to understand the resistances or the practical barriers.
Hi, so it's James Plaistow. So firstly, I'd just like to say thank you to Kathy and thank you to Maureen for excellent presentations. I'm a big fan of trying to use outcome measures to change clinical practice. And I'm wondering what ideas people have about how we could share some of the innovations that are taking part in clinical teams. I think it's quite a novel, different approach from sort of having like what used to be the sort of policy implementation guide to sort of do it the other way around and have sort of local innovation.
Absolutely, and that's what is so exciting, because it's that classic thing about knowledge as a precursor to improvement or behaviour change, but it doesn't in and of itself bring about the improvement. So policy can be wonderful, but policy then has to be implemented, so people have to want to adhere to it. So I totally agree with you. If things are being driven directly from the teams involved, then that's where you're going to get the traction. Then sending out a policy does nothing.
Can I make a comment, which is there are various opportunities where articles are invited, and in fact that might be one forum where people can share on what they're doing in relation to outcomes. So when those opportunities arise, those may be two opportunities: the newsletter and maybe some of those online opportunities that I know the Royal College are going to look at for sharing progress in relation to that, and what people are actually doing at a local level in terms of using the data in creative ways. So those are two things that I would say, and certainly we can take on board and think about that. I think in terms of the national report, it's quite prescribed. It doesn't really allow for that kind of detail, but it is something that we can talk with NHS England colleagues in terms of, particularly with this focus on outcome measures, about how we can build on this webinar to actually bring in examples to help encourage services to think about using the data. The other thing I was going to say is just thinking about time points in both a weekly calendar, monthly calendar and annual calendar for early intervention services, and thinking about opportunities to reflect on the data, perhaps when as part of introducing a new case that's come on the caseload, or as part of formulation meetings, actually queuing people in to say, well, what was their dialogue score? What is their QPR? How have they rated QPR? The same in terms of care planning meetings, having a queue to reflect on previous progress from a previous baseline score to make sure that you've actually got those as part of the processes. And then for those who are involved in case management supervision, using that as an opportunity for saying, well, let's have a little look at how they're doing on the dialogue in QPR, what was their original score perhaps, and if it hasn't been, maybe this is an opportunity to do it, particularly if a case manager feels they're getting nowhere, or they feel that perhaps there are someone's disengaging or whatever. It may be an opportunity to try and review what's going on. So I was just thinking, I mentioned about team away days, business meetings, those kind of things, but there are some routine clinical opportunities where we can perhaps embed some of this data at an individual level and actually reflect and encourage one another to use the data on a more regular basis rather than just a one-off annual audit.
And if I could just offer, it's a very interesting point, James. I guess all I'd offer from my perspective is that having worked across, local innovation through to regional and policy initiatives, I think what policy provides is a scaffold for innovation to grow up. And without that scaffold of policy directives and initiatives, it makes it very, very hard to sustain local innovation. They work together, and I think that the policy team work very hard to provide that scaffolding for local innovation to grow up and to utilise, but they work absolutely hand in hand. That was the only thing I wanted to add.
Brilliant. Thank you for
just say one more thing, which was about regional meetings, because there are regional network meetings and there are leads who coordinate those meetings. And again, James, that might be an opportunity to talk with your regional lead about having a focus on use of outcome measures and actually providing a platform and an opportunity to share on the work you've been doing, and maybe some other teams within that region who might also want to be part of that. That's another opportunity where you can share and learn from each other.
I mean, whilst we're waiting for other people to chat or kind of come on, certainly as part of the I2 project that Kathy mentioned, we have worked with all of our teams across all of the different sites, and we absolutely now use telephone consultations to collect as much data as practically possible. So our research assistants are sat there with the kind of scores, sorry, not the scores, with the outcome measures, and they go through the outcome measures, collect that, and then put it straight onto the electronic patient record or the research database as required. So I agree. I think that I think we're all mindful that COVID has pushed us along quite quickly in terms of thinking about how we can use online, telephone and video kind of discussions in a much more meaningful kind of way. So I think that's a very, very valid thing to be doing. Get things on.
So I suppose I was wondering, so it sounds like the answer is over the telephone, because I suppose I was wondering if, there's a way to send people a link so that they can do it. It just feels like in a lot of other contexts, we would be giving people that option now to click on a link by email, and obviously having to think about how secure that was, and just that might really improve things for us in terms of collecting our outcomes. And you know, especially in terms of working in EI, when you know a lot of our clients tend to be, you know, a bit more techie and maybe not like using the phone and things like that.
Yeah. I must admit, I personally have not got any experience of using it actually fully online via a link. But I'd be fascinated to hear if anyone has done. As I said, our strategy to date has been just utilising the phone. But you know, so many things. It's so easy, isn't it, to fill in things on your phone nowadays? It would be really interesting if anyone has been doing that.
I also think one thing that's important is the conversation with the service user, though, in terms of their responses. And if you go back to Kathy's presentation, which was about perhaps missing something, and that actually doing the measures actually led a whole review about the focus of the care plan, because realising that it wasn't housing, it was another issue. So I think one of the concerns about just a pure online is it might not get looked at or be used as part of a discussion or part of care planning. So I think there needs to be an interaction element, even if it's completed online, that the review of what someone has put in is discussed as part of their individual care plan review or their annual review, so that then you're looking that you're on track. I know that when I was working in services, that when we had paper-based data, you ended up with piles of paper data that no one looked at. So I think anything that helps with that process, certainly when you're looking at service outcomes, to have electronic data is really, really helpful. When as a lead or a manager, you want to look across a whole set of things, that is much more helpful than having to go through records to try and find paper copies and score them. But I do think at an individual level, if you're going to use it, which you know is what we're trying to encourage for care planning, and also reviewing how EI is doing, what you're doing with the person, then I think there has to be an interactive element with the person who's completing it.
Yeah, very thoughtful as ever, Joe. I think that's a really, really important point.
I guess I kind of wanted to add to that point. I don't know what scope we might have either locally or more nationally to think about app development. I don't know how many people have been maybe using the COVID-19 daily collection app at the moment. It's incredibly simple and very user intuitive. But I think if we're talking about the idea that maybe service users might want to collect their own data more often and keep a personal record of what they're filling in the same way that quite a few of my service users with bipolar use a mood diary or use an app-based mood diary, and then might share it with me in appointments so that we can see a more useful trend, whether using something like that so that then service users have the option to fill it in as they would like to fill it in, and we have the option to review it when we need to or when we'd like to formally collect the data. But I don't know what options we might have for that, because I think it would be really useful.
I don't know whether there is an app version. I don't think there is there, Paul? I don't know. Would you know?
So Dialogue was absolutely developed in that kind of way. So Dialogue does have an app-based version, and I think, Beth, that's a really important point. And you know, clearly that's where we'd love our system to be. I think sadly, when you look at the data, you know, it's only a couple of years ago that we had, you know, hardly any outcome data there whatsoever. If this can drive us to a point where we don't need to look at how many people have paired outcomes, but what the scores are for people, and the impact of our treatment on those scores, that's clearly where we want to be. And I think that, you know, your vision of having all of our service users being able to track their own recovery journey has to be our long-term vision. But I think we're a little way off that nationally as a system of care. And I suppose that's what we have to try and do, encourage that overall system change. But if you're doing that, if that's what you're doing on a regular basis, then that seems like great practice to me, and huge well done. I think it's really marvellous.
I think it would be useful. I mean, I don't know. Obviously, we haven't had anything like the NHS Hack Days this year because of coronavirus, but it's the kind of thing that would be useful. I don't know if people are familiar with the NHS Hack Days, but it basically means that clinicians go with ideas and then various tech developers come together with them and think about how they can implement it. I know some clinicians in my health board have been involved in it before for things like tracking why people don't come to outpatient appointments, for example, by using the weather input and systems like that. But it might be useful if people have those connections, or if we could think about it maybe as a Welsh national project. It might be something we could do.
Yeah, lovely.
Yeah.
I mean, it's important to remember that dialogue was never really ever designed as an outcome tool. It was designed as a care planning tool. So pretty much aligned to your comment earlier on, Joe, about it being a conversation with people as opposed to just a simple box ticking. That's how the dialogue was always envisaged, that it's something that you went through with somebody, pretty much on an app, but it involved an aspect of communication and discussion and collaboration about what are the important things for people, as opposed to just a box ticking of, 1, 2, 3, 4 on various items. So the dialogue absolutely, I think, was a really interesting kind of tool and choice. But the app's well worth a look at. It's quite sophisticated and good. And we'll see if we can get the link to that.
Hi, I just wanted to share with you that we take dialogues probably around initial assessment time. We then do it 6 weeks later. We will then record it 12 weeks later, 6 months, year, and then we go half yearly for the next 3 years, next 2 years, the pathway. I think I said on the chat line that it's been developed as an electronic document that goes directly into the patient's electronic record. I think this was being devised before COVID-19. It wasn't just coincidental. It went live about 2 weeks before we went into lockdown. But it's been a great way. We've been doing welfare checks, telephone welfare checks with our service users, and it's been a brilliant way to assess how they are by using that tool. So it's really been a wonderful tool to use.
Where are you, Debbie? Which intervention service?
Hertfordshire Partnership Trust.
Right. It's just if people are listening and perhaps want to contact outside of this,
yes,
then that would be very helpful. So if people have got things to share, if you can say where you're from, it does allow a bit of cross-fertilisation.
Yeah.
What I'll do is in the chat, I'll leave my email address.
Great. That's really helpful.
It's a real measure of added value, isn't it, of outcome measures beyond all of the stuff that we heard about earlier on. That's exciting.
I think one of the things, just commenting on what you've said, is that originally, I think people saw, obviously QPR and Dialogue were introduced nationally, and I think people saw it as national measures that we have to do and then which are audited. But one of the things, and what you've sort of highlighted, is exactly what actually it's intended to do, which is intended to both help steer care planning, but also to monitor outcomes on an ongoing basis, and about the process experience for service users. And I think it's that we're keen for it to move from being, this is something we have to do once a year to make sure we've done it for the NCAP audit, to being something that gets integrated into practice. And you've just epitomised that in terms of what you've just said. And then also that people use it as well to monitor their service outcomes. And I do remember in Worcestershire that, at business team days once a year, we'd try and collate data across service users. And there's nothing more rewarding for care coordinators and staff who've been working their socks off to actually see it in black and white, that actually you are influencing outcomes, you're making a difference. So that's the other aspect of it at a service level, to actually use it to monitor what you're doing and whether you are reaching the parts that other beers haven't reached, and whether you are successfully achieving the, what you say on the tin you're trying to do. It'd be interesting to hear other people, whether they're using measures in either way, either with individuals or at a service level.
So the first one was around whether it's possible to source or put together some QI training for all EIP staff across Wales. I guess that's something that Maureen might want to think about or look into.
Well, I would suggest that that's probably discussed with the Improving Lives group, and her name's just gone out of my head, Paul. Who? Just
Michaela?
Michaela. Michaela would be the person to talk to in the 1,000 plus Improving Lives, because she is the quality improvement lead in Wales, and I'm sure would be very happy to host a day looking at that. And indeed, there is an EIP steering group, so people who are on the call from Wales who are on that steering group could suggest that to Michaela. And certainly, as I say previously, Paul and I have been involved with QI Days in Wales, and I think there isn't one planned for this year that we would be part of, but certainly next year there would be. But certainly talk to Michaela.
My name's David Kenny, and I'm a family therapist up in Merseyside, so I lead on the family intervention part of the service. Just, again, it's more of a comment really. So I work across 2 different teams, and the hub manager of one team sends out very regular, probably weekly emails to the whole team that records the percentage of outcome measures that needs to be completed. And in the other part of the service, they don't do that. And care coordinators report it being sometimes not, they don't always welcome to be that kind of information, but it does enable them to complete the measures and get the measures sorted much quicker. So I just wondered whether for any teams who are out there who maybe don't adopt that style of getting those reminders out so regularly, that's something that potentially could be an option for them.
Great idea.
Yeah, really helpful. And it's been joyous. I've had the real pleasure of being able to support Merseycare over the last few years in relation to their EI, and it's been phenomenal the success that's been achieved over in Merseycare, from what was, you know, only a couple of years ago a really difficult position to now doing some incredible kind of stuff and really leading some of the field around some of this. Great to hear you're in post and grit and doing stuff and really pushing forward on the outcome data. Yeah. Brilliant. Huge thanks.
Thanks, David. And we've got someone else here. If you'd like to.
Hi.
Hiya.
Hi. So I'm Liz from the Swindon Early Intervention team. I was just going to add, kind of echo that actually, that good admin and those reminders are really important. We really struggled at the start, but we managed to get a couple of champions in the team that were really up for using the outcome measures, and actually got our peer mentors involved in doing them as well with our service users. And as the feedback came back in from service users, particularly when they did the 6-month or year one and were able to see how things had changed for them and progressed for them, or things had slipped back and the reasons why, that was really handy for our care coordinators to hear that actually service users and peer mentors were finding them incredibly useful.
Great. One thing I found within my team, I don't know whether you have either a team away day or a business meeting, would be to take some of the data to see whether you can get someone who can take some of the data and actually look at the changes on the data and present it to colleagues, because that again is a way of getting buy-in when you see the results of you collecting this data actually processed. Because sometimes you're so busy, it's just shoved in a file, and you don't actually, unless you either sit down with the service user and reflect on changes in the scores, which is one way of doing it, but the other is as a team to actually look at the impact you're having. And you could do that as part of a formulation, or as a follow-up, or as part of an away day. Thinking about, let's take this data and let's have a look at it. Let's look at what we're doing. So you're using the data within the team rather than, as Paul said, seeing this as an exercise where we're feeding some kind of audit piece once a year. Let's try and think about ways to feedback so people can see the value of it, either at an individual level with service users or as a team, to see how it's monitoring progress.
Could I just ask, Steph?
Yeah.
I mean, I think the other point about just administrative support is incredibly important. You know, we know that anything that we can do to kind of help our care coordinators or people who are going out and seeing people, just to remind them, have you got some measures with you? Have you got something to take out? And when people come back, can I take those and help put them onto the system? I think anything that we can kind of, you know, do to support our clinical colleagues with the great administrators that we have in the system is so bloody important, and oftentimes can be just so undervalued. So ensuring that good admin and enough admin is part and parcel of your business case is a really important issue. So thanks for that reminder.
There's a comment on the Q&A from Lynn Dixon saying that in the Southwest Clinical Network, we're using the data to discuss areas of improvement within the region, so we can then buddy up teams to have learning days together and take away practical tips on making improvements. Taking time together really benefits teams to hear how each other are coping with challenges and how they're overcoming them. So that's really helpful, Lynn, that comment. And again, a suggestion that you buddy up, and you could do that either as teams within a service, within a trust, or across trusts. Perhaps even thinking about it at a regional level, saying, shall we have a regional network day where we actually bring along some data and actually have a look at this and look what we're doing and look at how we're achieving both the collection of data, but also how we're using it and how we can learn from one another about using it better or improving our collection.
Lovely, thank you. So we don't have anyone else raising their hands at the moment. I wondered if there was anything else that you wanted to kind of suggest or discuss together.
I think the important thing is to make the data useful for your service users and for your care coordinators and for you as a service, rather than seeing that these were imposed by government, these were measures imposed by government, which we have to do for an audit. I think if you can get over that mindset, and even perhaps as a starter point, encourage a care coordinator to just take one service user and to sit down and use the assessment to reflect on either areas of focus for goal setting or in terms of thoughts and feelings the service user has in relation to their current position, and then to repeat that and just see what the impact is with one service user, to try and just get people using the data and building it into care planning processes, so that as part of care planning, there's a reminder that you collect the baseline, or as part of any, you know, we normally used to do our assessments within the first 6 weeks, that was done, but there was a review built in where that was pulled together, and then in a subsequent care plan, that is revisited, that it's made sure that it's completed, and you can look, as Kathy suggested, at change over time. What things are we impacting on? What things have we made a difference in? What areas do we now need to focus on? And certainly I think dialogue and QPR were chosen because they're short, but they were also chosen because they look at quality of life, satisfaction, and also those areas in terms of, from a service user perspective, those things that are impacting on their feelings about life and their quality of life and their future. So I think if you can try and build it in, but just try and encourage colleagues just to, if they've done a baseline, to have a go at looking with the service user. And again, in case supervision, managers or supervisors should be encouraging care coordinators to say, well, let's look at what's happening in relation to changes on those measures, either as a prompt to do them or to look at the data. And we've made the suggestion as a team through away days or other means. Make them useful for service users, make them useful for care coordinators, make them useful for the team and service.
I think it also talks to that whole thing that as human beings, when anybody asks us how things are, we tend to think about what's not going so well. And if you've actually got data that shows you, reflects on your improvements, then that's kind of a really powerful thing, isn't it? To sort of see, I was feeling that way around this, actually the work we've done now has improved things. And I think that's just such a powerful thing for us. I think somebody else has put their hand.
You've got David wanting to speak. Hi, David.
Yeah, hello, hi, thanks. Yeah, just me again. So absolutely 100% agree with everything that's been said so far by the colleague down south and yourself, Joe. Just wanted to also kind of reflect a little bit that I worked in Commons for a long time, and we had a very similar difficulty over there with what was known as routine outcome measures. So a psychologist actually led on making them changing the name and reframing them, rather than an outcome measure, to a therapeutic ROM, which was therapeutic routine outcome measure, and did some workshops trying to help people use the worksheets as a tool to increase curiosity with the service users, which I think can be, and I don't think it has to be led by a psychologist at all. I think it's a joint responsibility or to have champions like my colleague down south there. But also I attend the complex case formulations, which gives care coordinators an opportunity to bring some of the more kind of complicated cases that they have to a kind of MDT style, I guess. And I've just noticed, just thinking to myself here, is that we don't actually touch upon what has been reported or recorded in any of the outcome measures. So I think that's something I'll take back to my team and see if we can get the most recent, actually any time 1 or time 2 measures and compare them and just see what actually the service user is asking for.
Yeah, we used to have formulation meetings where we'd take a couple of new cases and formulate them. And again, that's another opportunity where you might reflect on people's baseline measures in terms, again, thinking about how that might be impacting on their presentation in terms of areas, perhaps proximal factors that may be affecting their mood and their coping, but also some of those attitudes and beliefs that may be impacting on perhaps, suicidality and other things. So again, another opportunity is, if you do formulation meetings, is to build them in there.
Yeah, thank you.
Thanks to everybody, those people who presented, contributed technical, and those of you who joined. Thank you very much. Stay safe. Bye, guys.